they really find it interesting. We have to at least do something. I mean, this message was there.
It's 10 o'clock. Should we get started? Would someone like to do an introduction, Dr. Abdulahad? Would you like to just get us started briefly?
Bismillahirrahmanirrahim. So, guys, as we have already said that this is a non-graded teaching learning activity, and we are doing it just to establish a link between the structure function and the clinical context. And thank you very much for those groups who have discussed and after consensus have submitted their answers to me. I'll go through those answers, and if there is any, if their answers are not appropriate, then what we'll do, I'll just, after consulting with the concerned faculty, I'll respond to them. Only those groups whose answer is not up to the mark. For the rest of the things, it's okay. The idea was just to discuss this in the group, and then finally, after discussing in the group, it should be discussed by one representative, because we cannot handle the whole class at the same time. That was the idea. So Alhamdulillah, about 25 students, half of the group have already sent me the LGD by 9, so which is a good thing. But we also expect that the all group have discussed these questions in their group, and they have already prepared their answers. If not, then the group the TBL group leaders will discuss these answers with them. But please be reminded, we will not record these, and it will not, the model answers will not be placed or will not be posted onto the Moodle. Thank you. Dr. Ahmed.
Right, okay, so I think the way we should probably try to conduct this as well is that we're going to go through each of the cases and each of the resource faculty for each of the particular questions. You can try and handle those questions as well. Each of these cases were written up by the faculty jointly. They've done a really nice job. So if you do have any questions, because of time, we'll see if we have the time. But always remember that if you do have any specific concerns or questions, you can always contact the specific faculty by email, and they should be able to help you out. So should we go on to the first scenario?
Bismillah.
Yes.
Right, okay, so a 72-year-old male presented in clinic with complaints of difficulty in urination for the last 6 months, with feeling as though he cannot empty his bladder completely. He used to wake up more than 10 times in the night, and after voiding, he often feels as though he needs to urinate again. On examination, he had a palpable enlarged bladder, which is firm in consistency, even though he had just voided. His serum electrolytes were normal apart from urea, blood urea nitrogen, or BUN, of 20 millimole per liter, that's 56 milligrams per deciliter, and a creatinine of 240 micromolar per liter, which is 2.7 milligrams per deciliter. So the first question, describe the normal micturition reflex. The first urge to void urine is felt at what volume in the bladder? So who would like to answer? Who would be the resource faculty for this question?
I'll take this question.
Okay. The floor is yours, Dr. Abdullah.
Okay. So the first urge, we'll take the first component of the question, describe the normal micturition reflex. As you all know, the micturition reflex is a spinal reflex. The urinary bladder, when it has receptors, or we can say stretch receptors, once it senses, these stretch receptor senses the filling of the bladder, the information goes through the afferent to the spinal cord. And then from the spinal cord, this information comes back to the urinary bladder, and it contracts the detrusor muscle and also causes relaxation of the internal sphincter. And if the higher centers are not inhibiting, the involuntary process of urination takes place. So this is, but remember one thing, what we need to understand is the micturition reflex is, it continuously goes on, but once it is inhibited, it remains inhibited for from seconds up to an hour. After that, the next micturition reflex starts. So this continuation of involuntary reflex is purely a spinal reflex. And the second part of this question is the first urge to void urine, at what volume the first urge to void urine takes place. Usually when there is 150 ml of urine in the urinary bladder, we feel the first urge to void urine. And after that, the initiation of this takes place again and again. I hope it's clear.
So does anyone have any questions, any concerns? If you do have any questions, either type it down in the chat, or if you feel more comfortable, you can raise your hand and we could unmute you to ask your question. Okay, we'll go on ahead. If you do have any questions, you can always raise your hand and we can ask them later on to any of our faculty. Okay, so for the second question.
Okay, so this question, I'm going to take it. The question says, which zone of the prostate gland is most likely responsible for this problem? So, as we know, there are different zones which are present clinically, which we talk about when we talk about the symptomatology which is related with the prostatic problems. So, the zone which is surrounding the prostatic urethra, and that's the transitional zone. So the transitional zone is the zone, if there is enlargement in this pertinent zone, that will be responsible for giving us the symptomatology, the sign and symptoms of enlarged prostate, which will present all whatsoever has been mentioned in the above given vignette. Is this question clear? Any concern for this answer?
Okay. While we're waiting for the question, Dr. Abdulahad, there was a question for you. Is the micturition reflex lost with age?
Is the micturition reflex lost with age? It depends on the underlying pathology. For example, if anything which damages the afferent nerves, the spinal centers and efferent nerve, it may do so. So any damage to the afferent, the receptors, the afferent nerve, the efferent nerve, and the spinal center may cause. For example, we call it as a neurogenic bladder, and we have discussed it in my lecture. And there are different types of neurogenic bladder. We have discussed at 4 levels: at the higher centers, at the pontine center, between the pontine center, and if any damage into the spinal cord up to this in the cervical, in the thoracic region, and any damage at the we can say at the S2, S3, S4.
Okay, I can see a question which has been posted for myself.
Two
This
questions.
question, yeah. So this question says, for me is only one. You usually, okay. So what is the transitional part? And the first part is, we usually see enlargement in the central portion of the gland. So guys, we have to differentiate central portion from the central zone. So the transitional zone is that part of the prostate gland through which the prostatic urethra passes. And so it's surrounding the part of the prostate gland which surrounds the urethra. That is the transitional zone. And once we have enlargement in this zone of the gland, that is responsible for the decrease in flow of urination. And this ultimately will result in causing all the symptomatology, all the signs and symptoms of decrease in flow and resulting other issues which are connected to that. I hope I'm able to answer your question, or is there anything for me more? Thank you, I got it.
Again, I just want to add to that part of.
There is something for me.
Okay.
Is that BPH? Yes, this is the benign prostatic hyperplasia or benign prostatic enlargement. Transitional zone for BPH, peripheral zone for cancer of the prostate.
Dr. Abdulahad, please continue.
Yes, I just want to say that, I mean, regarding responding to the comment that is the maturation reflex lost with age. Under normal physiological conditions, if everything is normal, if all the receptors, sensory apparatus, and the spinal center and the motor nerves are intact, it will not be lost. If there is any pathology, it may lost. I mean, and it is not related with the age. But under normal physiological conditions, it remains intact.
All right, wonderful. Unless there are any other questions, let's go on to the third one. If you do have any other questions that come to mind, please type them in the chat. Okay, question 3. Why are the plasma urea and creatinine raised? Suggest with a reason, the effect, and the presentation on GFR.
Dr. Junaid, that's mine.
Yes, yes, sir. Please go ahead.
Okay, Assalamu alaikum, students. It's nice to see, what's it now, 66 people on this chat. I felt a little bit alienated with having only 20 people listening to my lectures, so I feel a tad bit encouraged. Let me go back.
One of them, Dr. Abdul Jabbar.
All right. Let me go back to the scenario. It says on examination he had a palpable enlarged bladder, which is firm in consistency, and even though he had just voided. I hope the class understand what the word voided means. Okay, and they understand, as Dr. Abdulahad pointed out, how much a urine is excreted or released from the body during voiding. But there's my bit. His serum electrolytes are normal, and the assumption here is that things like sodium, potassium, calcium, and so on and so forth, those are normal. However, his urea, and in brackets it's written blood urea nitrogen, or BUN, is 20 millimoles per liter. And the BUN, which is normally given in milligrams per deciliter, is 56 milligrams per deciliter. Now, if you go back and look at a standard textbook, it will tell you that the normal urea content of serum should be around 7 to 18 milligrams per deciliter. So this one is obviously elevated. Then it says a creatinine of 240 micromoles per liter, which works out to approximately 2.7 milligrams per deciliter. And for that one, the normal value should be around 0.6 to around 1.2. So according to the scenario, both of these electrolytes are elevated in in the blood or in the serum. So the question says, why is this so? Now, the thing you have to keep at the back of your mind is both of these solutes, both of these electrolytes are being filtered in the kidney at the glomeruli. So they get filtered from the capillaries into the Bowman space. So if they are not getting filtered, in other words, they are accumulating in the plasma. Now, it either there's something wrong with the filtration membrane. In other words, your endothelial cell on the capillary, your basement membrane, or your podocytes. On the other hand, it could be that this quantity called the glomerular filtration rate is decreased. Let me remind you that the glomerular filtration rate would be the amount of a substance that's, or the volume of plasma from which a amount of substance is removed. So if the glomerular filtration rate is reduced, more of these substances, such as urea and creatinine, will stay in the blood. So let's just think about this for a minute. How do we measure glomerular filtration rate? And there are 4 ways in which you can do this. So way number 1. And the first way is glomerular filtration rate is equal to your KF value, in other words, your filtration coefficient multiplied by your ultrafiltration pressure. Okay, and your ultrafiltration pressure is your hydrostatic pressure, your oncotic pressure, and so on and so forth. So that's one way to get glomerular filtration rate. In this case, we are given no pressures, so we don't know what's happening. Okay, the second way you can measure glomerular filtration rate is to infuse inulin, okay, to put the patient on an IV line of inulin and then measure plasma inulin, urinary inulin concentration, and urinary flow rate. In this case, none of those are given, so we cannot estimate that. The third way, we can look at creatinine. Now, we can either look at creatinine clearance. That would mean getting the plasma concentration of creatinine, the urine concentration of creatinine, and the urine flow rate. Now, even though we are given the plasma concentration of creatinine, we do not have the urine concentration of creatinine. And now let's look at the fourth way that we can estimate glomerular filtration rate. And I mentioned to you that in the clinic, a quick way to measure glomerular filtration rate would be to look at plasma creatinine levels, because plasma creatinine levels are inversely proportional to glomerular filtration rate. So if you're looking at the normal glomerular, the creatinine level of around 1.1, say, let's just make it 1. The normal glomerular filtration rate would be about 125 milliliters per minute. Now, if you notice in this case, this guy has a glomerular filtration rate, or a creatinine level of 2.7. Now that means his glomerular filtration rate has decreased by half. So he's gone from about 125 to about a 60-ish kind of thing. So his glomerular filtration rate is evidently decreased, and this is the reason why he's retaining both urea and creatinine within his plasma. So he's not getting rid, or he's not filtering sufficient amounts of both urea and creatinine. The question is, why? Now, as Dr. Atif has mentioned, you're having hyperplasia of the prostate. If you have hyperplasia of the prostate, you cannot get rid of urine from the bladder. So even after voiding, there is more than a normal amount of urine in bladder. Hopefully, I will let Dr. Abdulahad pick up on exactly how much and so on and so forth in a minute. So if the urine is accumulating in the bladder, that means you have a backup, if you want, of pressure in the entire urinary system. So you're having a backup of pressure in the ureter, you have a backup of pressure in the calyx, you have a backup of pressure in the pelvis. And this backup of pressure is essentially coming all the way up to the Bowman space. Now, let's go back to filtration. For filtration to take place, I need three pressures. One is the capillary hydrostatic pressure. The second is the capillary oncotic pressure or osmotic pressure, whichever you want to call it. And the third one is the Bowman space hydrostatic pressure. Now, if this pressure is being backed up all the way up towards the Bowman space, that means the Bowman space hydrostatic pressure is higher than normal. And if that is higher than normal, I am going to decrease my glomerular filtration rate. And if my glomerular filtration rate decreases, I'm going to get rid of less urea and less creatinine from the blood. I hope this makes sense. And, you know, as usual, you can ask a question now, or you can send me by email, whichever pleases you. Thank you, Dr. Junaid.
Right, wonderful. Is there anything that Dr. Abdulahad you wanted to add? Dr. Jabbar mentioned that maybe you would have something to add as well.
Yes, as the volume of urine in the bladder increases, it increases from 0, then 50, then 100. The first urge of urine void starts at 150, and once it is inhibited, it remains inhibited for up to hours, from minutes, from seconds to hours. And then formation of urine is a continuous process. So the amount of urine being accumulated in the urinary bladder increases. As we know that the detrusor muscles are the smooth muscles, and the smooth muscles have the property of stress relaxation. So they relaxes and then they accumulate more and more urine. Once the stimulus starts with the next, initiation of the sensing of these stretch receptors in the detrusor muscles or mechanoreceptors in the detrusor muscles, then the next, the afferent signal goes to the spinal centers and it goes on. But it has to be, if it is socially acceptable, then involuntary we avoid urine. If it is socially unacceptable, then we hold the urine. This is the mechanism. And I have discussed this in one of my slides of cystography. So it was very much clear in that slide.
Wonderful. Thank you so much, Dr. Abdulahad. Dr. Jabbar, we had a couple of questions for you. One question was the last part where you mentioned about backup pressures. Could you repeat that, please?
Sure. Let's go back to normal glomerular filtration. I have an afferent artery coming in to my Bowman's capsule. I have an efferent artery going out. And I create within the difference between, the constriction between those two will create something called a hydrostatic pressure. That hydrostatic pressure is what pushes my plasma, except obviously the proteins, through my ultrafiltration membrane into the Bowman space. So I have glomerular hydrostatic pressure. That's one pressure. The second thing is, as the filtrate minus the proteins are being pushed into the Bowman's capsule or the Bowman space, the proteins that are remaining back will now exert what is called an oncotic pressure or a plasma osmotic pressure, whatever you want to call it. That has the effect of preventing fluid from leaving the capillary. The third pressure is, as the fluid is accumulating, or we should rather call it now the filtrate, as the filtrate is accumulating in the Bowman space, just before it starts heading down into the proximal convoluted tubule, that fluid exerts a hydrostatic pressure. That's what hydrostatic means. It's due to water. So that fluid will exert a hydrostatic pressure, and that will exert a hydrostatic pressure out of the Bowman space towards the capillary. So if we take this again, The hydrostatic pressure in the capillary is pushing out. The hydrostatic pressure in the Bowman space is pushing back into the capillary, and the plasma oncotic pressure is preventing the movement of fluid from the capillary into the Bowman space. And what you are increasing in this particular clinical situation is you are increasing the Bowman space hydrostatic pressure. Now, even though you're not putting in fluid there, what you're actually doing is by not allowing the urine to pass, that pressure that builds up all the way down in the bladder may come all the way up towards the nephron. And that pressure is being exerted as a Bowman space hydrostatic pressure that's preventing the filtration from taking place. Thank you.
Wonderful. Is that hopefully that's been cleared up. Dr. Jabbar, there was also another question.
Yeah, that's for me. That's for me.
All right. Okay.
Thank you, guys. Thank you, guys. You help around the whole thing. So if you look at the scenario, it's all about an old person who is struggling to empty his bladder, and he is making different attempts but unable to do so. So what's the reason? We talk about it. He has an enlargement in his zone of the prostate, and that is causing constriction of the part of the urethra which passes through that, and that zone is the transitional zone. So what happened exactly? As a result, there is an obstruction to the outflow. Now the detrusors are trying to empty the urine which is present in the lumen of the bladder, but the lumen is being narrowed down. So in that effort, the detrusors are exerting more and more and more and more, and which will lead to hypertrophy of the detrusor muscle. So in other words, it will increase in pressure within the lumen of the bladder, and that will cause the urine to flow upwards, like it was being mentioned. So thus, then the urine starts going back into the ureters, urine starts going back into the kidneys, and then causes all what has been mentioned. But what happens? So if you see in the lower part that on examination, the patient has a palpable enlarged urinary bladder. So, and that is firm inconsistency. So the word firm, we know. So it's not hard. If it is hard, then we could have think in a different way. So it is a firm consistency. You know what is firm. And so now, even he has voided, but there is some volume which has been retained in his urinary bladder. Now it's about time that, like the question says, list one important clinical examination to be carried out in this case and why. So the important clinical examination which has to be carried out in this pertinent situation is digital rectal examination. And we all know when we insert the finger through the anus into the rectum, we are just palpating the posterior surface of the prostate gland. And we all know when the prostate enlarges its posterior surface, there are certain changes which are occurring. We talk about those. So if, so we have to do the test. What we have to do is the digital rectal examination. And now why? Because we have to determine that what are we handling with. So we are ruling out that is there no other possibility of having any malignancy or any kind of inflammatory situation. The vignette is more going in favor of an enlargement of the prostate. So the important clinical examination which has to be carried in this situation is the digital rectal examination. And why? Because we have to determine, there are so many factors, but at your level, what I'm trying to say, we have to differentiate that are we handling a benign disease or are we handling a malignant disease? I hope I'm clear. Is there anything which bothers you? Please feel free to write in the group chat.
Okay, that's wonderful. I think then, so Dr. Atif, did you also handle the question number 4 as well, or is this the scenario is done now?
I think question 4 I have talked about and scenario is done. I think we should proceed to the next scenario.
Yes, please. Next, please.
Dr. Atif, Atif, a PSA, please. Could you please just one sentence on PSA?
Okay, sure. Dr. Junaid, can you go back? So Actually, I didn't mention about PSA. The reason was the question says list one important clinical examination. So the clinical examination is what? Is digital rectal examination. Now, after that, we have to go PSA. PSA is a very, very specific test, and that determines a lot. That is quite helpful. But then we have to do a digital rectal examination, a PSA, and then we have to do a biopsy, which has been carried out through the anal route, through the rectum. So these are the things which has to be carried out. So this is clinical plus the other things which where we have, if we are suspecting that this is a malignancy, then we'll go for a biopsy and subsequent things. PSA tells us, but PSA values are important if we are hunting for that this is, are we handling with any kind of malignancy, then we should go for PSA. And then subsequently, so what is PSA? PSA is prostate specific antigen. There is a detail for that. We are avoiding that. Otherwise, PSA acceleration, PSA frequency, there are so many versions of PSA.
Thank you.
You're welcome.
If I may interject, this is Janti. We just have a question about, can we label this patient as a hydronephrosis patient, since urine will be built up in the kidneys eventually? This is one of the questions in the chat.
Hydronephrosis, I think we can call it as bladder outflow obstruction. And bladder outflow obstruction is the main cause, which results subsequently to hydronephrosis, and that will cause all other changes, and the end result may be azotemia.
Okay, wonderful. If that's it, should we go on to the next question? The next scenario, there we go. Okay, so a 24-year-old man presented with dizziness and weakness. He had a previous history of tuberculosis. On examination, he was dehydrated and had a low blood pressure of 70/40. His blood results showed a plasma sodium of 125 millimolar per liter, potassium of 6 millimolar per liter, creatinine of 110 micromolar per liter, which is the same as 1.2 milligrams per deciliter, and glucose of 3 millimolars per liter, which is 54 milligrams per deciliter. The first question for this scenario is, describe the normal reabsorption of sodium by the nephron.
Okay, I'll take this question.
Floor is yours.
Okay. So guys, you know, the sodium is important and one of the important electrolyte. Sodium reabsorption by the nephron. We take about, sodium is reabsorbed throughout in all the segments of the nephron. Sodium is reabsorbed, but it is not secreted. So whatever the filtered amount of sodium is, it is reabsorbed throughout all segments of nephron, and only 1% is excreted out. As I have told you in the lecture, that about 25,200 milliosmoles per day sodium is filtered. Out of this 25,200, 25,100 is reabsorbed, and only 100 milliequivalent is excreted out. So there is no secretion of sodium, only it is excreted, and this amount which is excreted is 1%. So if we, and let's take the reabsorption process in different segments of the nephron. In the proximal tubule, 70% of sodium is reabsorbed. And this reabsorption, the important thing here is, at the luminal site, in the proximal tubule, we have sodium reabsorption. It is through co-transport mechanism, and sodium is reabsorbed along with glucose, amino acid, phosphate, and lactate. And again, there is another mechanism in the proximal tubule, which is sodium hydrogen countertransport. So these mechanisms makes the absorption of sodium in the proximal tubule, which is the 70%. The one important aspect here which we need to understand and take into consideration is sodium is reabsorbed along with water, and we call it isoosmotic. Amount of water is also reabsorbed along with sodium. And that is the reason we call it the isoosmotic. It means with the change of GFR, if the GFR increases, similarly, similar amount of water will be absorbed along with the sodium, reabsorbed along with the sodium. So this is regulated by GFR. If we come to the second part, which is the thick ascending limb. Thick ascending limb is the part where sodium is reabsorbed along with sodium chloride potassium co-transport mechanism. And this sodium chloride and potassium co-transport mechanism is responsible for reabsorption of sodium in the thick ascending limb of loop of Henle. But remember one thing, here the thick ascending limb of loop of Henle is impermeable to water. It means only sodium is reabsorbed, so whatever the amount of present into the lumen, in the lumen we have only, since sodium is reabsorbed, so the amount of sodium in the lumen will decrease, and the osmolarity of the fluid in the lumen will also decrease, and it will decrease below the plasma levels. Now we come to the third component, which is the distal tubule and collecting duct. So in the proximal tubule, 70% is reabsorbed. In the thick ascending limb, 20% is reabsorbed, so we have 90%. 9% is reabsorbed from the distal tubule and collecting duct. The distal tubule and collecting duct has a typical feature, and those typical features are because of the two important type of cells present in these segments. One is principal cell, and the other is alpha intercalated. What happens in the principal cells? The principal cells, they reabsorb sodium and water. They secrete potassium, and under the effect, as the aldosterone increases, sodium reabsorption increases and increases potassium secretion. And that is what the mechanism is. In the collecting duct, or we can say in the collecting duct, this sodium reabsorption also takes place along with the chloride, which is co-transport. So in doing so, we have 99% of sodium is reabsorbed in the totally in the proximal tubule, in the thick ascending limb, in the distal, in the collecting duct and distal convoluted tubule. And only 1% of sodium is excreted out. So this is the mechanism, and this mechanism is important because the first part, where in the proximal tubule, the reabsorption is isoosmotic with the water. So it is the only segment where it changes along with the as the GFR changes. If GFR decreases, the reabsorption of sodium decreases, and also the reabsorption of water decreases. If the GFR increases, the absorption of sodium increases along with the water increases. Is there any question related to that?
Well, okay, if you do have any questions, please just type them down in the chats. In the meantime, let's go on to the next question. This question number 6, explain the regulation of the hormone controlling renal sodium excretion and describe its mechanism of action. This will be, who's this, Dr. Jabara? I presume this is for you.
Dr. Abdullah has done most of it, but I can add just one little point. He did a pretty good job at bringing both, or giving answers for question numbers 5 and 6. So as Dr. Abdullah pointed out, aldosterone is your principal hormone that's responsible for the absorption of sodium. Its effect is mostly in the distal nephron, and that would be in the cortical collecting duct, in the medullary collecting duct, and in the late distal collecting duct. Now, he also mentioned that there are two kinds of cells. These cells are called principal cells and intercalated cells. And this is the bit I'd like to add in, that aldosterone is firstly secreted by the adrenal gland. It's a mineralocorticoid by the adrenal gland. Aldosterone will bring about the insertion of, if you remember my lecture, I mentioned a sodium channel, okay, an epithelial sodium channel in the luminal side of the tubular cell. So it has two effects, if you can put it that way, or two mechanisms of action. One is to bring about increased transport in this sodium channel. And the second thing is it also stimulates the sodium potassium ATPase on the basolateral side of the epithelial cell. What is the effect of both of these? The first is stimulation of the sodium potassium ATPase creates a sufficient gradient between the lumen and the epithelial cell, sorry. And when the sodium is pumped in, the potassium is obviously pumped out because you're stimulating this pump. But at the same time, you're also allowing the sodium to come in through the channel on the luminal side. So these are the two ways in which aldosterone will bring about its mechanism of action in the distal nephron. Thank you.
Wonderful. Okay, again, any questions, just write them down in the chat. So let's go on to the next question. Describe the mechanism by which a deficiency of this hormone may account for the raised potassium level.
I don't mind starting on this one, Dr. Abdullah.
Please.
Okay. Let's go back to the scenario, please. So this guy presents, 24-year-old man, pretty young guy. He presents with dizziness and weakness. Okay, I'll come back to tuberculosis. Maybe Dr. Ahmad will deal with that later on, you know, autoimmune infection and its effect on the adrenal gland. But let's come back to the guy. He is dehydrated. Okay, so, you know, if you pinch his skin, you will find it takes quite a while for the turgor to kind of go down. So he's dehydrated. That's what the doctor probably did. He has a low blood pressure of 70/40. Now, those of you, you've done CVP block, you know, 120/80 kind of thing. Now, what could possibly indicate a low blood pressure? And I'll come to that question in a second. You think about that as I speak. So he's got a low blood pressure. His blood results shows a sodium of 125 millimoles per liter. And you know, roughly sodium is about 140 milliequivalents per liter. Potassium is 6 millimoles per liter. You should know that the normal potassium is around 3.5 to about 5. So he's slightly elevated in his potassium and his sodium is decreased. Creatinine is 110 micromoles, which is 1.2 milligrams per deciliter. From the answer to my previous question, this is kind of normal because about 1.1 milligrams per deciliter can be considered normal creatinine and therefore normal GFR. And lastly, his glucose is 3 millimoles per liter, which works out to about 54 milligrams per deciliter. You should know that normal is around 60 to 90 milligrams per deciliter. So if we summarize, his blood pressure is low, which is probably what is causing his dizziness and weakness. His sodium is low, his potassium is high, his creatinine kind of normal, and his glucose is low. So let's think about this. Dr. Abdulahad said that potassium's principal function is to regulate sodium reabsorption. So if you have a low sodium reabsorption, okay, then obviously your sodium level is going to be low. You only got 125 millimoles per liter, okay? At the same time, in exchange for sodium by the principal cells, you get potassium excretion or secretion. And notice, low aldosterone, you're not secreting the potassium, therefore your potassium is high. Your kidney is working reasonably well, that's the creatinine. But now it comes to glucose. Can you see glucose? Now glucose is 3 millimoles per liter. And the only suggestion for that would be that if your aldosterone is low, then there is a probability that the problem in the adrenal gland is also having an effect on glucocorticoid release from the adrenal gland. Because glucocorticoids will increase blood glucose, okay, in a normal individual. So if you do not have enough glucocorticoid and aldosterone, the glucocorticoid is not having an effect on the glucose, the aldosterone is not having an effect on the sodium and the potassium, and now this guy has this kind of clinical presentation. Now the question is, well, why is his blood pressure low? Now, you know, basic mechanisms here, either he has a hemorrhage, but there's no story of trauma in this case, or he has a decreased volume. In other words, he is losing too much of fluid. So if you are not reabsorbing the sodium that Dr. Abdulahad talked about in the distal nephron, that means sodium, which is osmotic, as it goes through the tubule, it will take along with it water. So if you are losing water with the sodium, that means your blood volume is going down. As your blood volume goes down because of the decreased aldosterone, your blood pressure now starts to fall and comes to 70/40. So that's the effect of the deficiency of, in this case, both aldosterone and glucocorticoids in causing this kind of presentation. Dr. Abdulahad?
Yes.
Anything else?
No, it's okay. You explained it pretty well. There's a last question, Dr. Jabbar, about the diagnosis.
Yes, so which organ is likely affected and what is the most likely diagnosis?
Yes, it's probably, it's definitely an aldosterone deficiency, and the fancy name for that is called Addison's disease. Which organ is affected? It's the adrenal gland.
That's wonderful. I think a lot of the students managed to figure it out beforehand.
Yeah.
Okay, so if no one has any other questions, what do you say? Should we move on to the final scenario? We have a question here, Doctor. I don't get why there is an increase in potassium.
Dr. Abdullah, do you want to take that? Yes.
Dr. Abdullah and Dr. Jabbar.
Yes. As we have already said that the aldosterone also is responsible for the absorption of sodium and secretion of potassium. If there is no aldosterone, so definitely the potassium value will increase because it is not being secreted.
Wonderful. So on the same line again, why was blood glucose decreased?
Because we do not have sufficient glucocorticoid coming from the adrenal gland. Glucocorticoids will increase blood glucose level. And if the adrenal gland is being affected in any way here, which is the case, the amount of glucocorticoids like cortisol is depleted. or is not there, and therefore we do not have enough, we do not have a stimulation in increasing the blood glucose level.
Okay, wonderful. I hope that's clear. Let's move swiftly onwards to scenario number 3. Right. Again, if you have any questions, please, of any of the other scenarios, feel free to write them in the chat section or make a note of them to send an email later on. So, number 3, a 30-year-old man presented in the ER complaining of agonizing pain in the abdomen that had lasted 4 hours. He indicated that the pain had started in the back on the left side and radiated into his groin. The patient was given an injection for pain relief and was admitted to a surgical ward. There, he was encouraged to drink as much water as possible. A sample of urine tested positive for blood. His plasma biochemistry showed a normal plasma creatinine of 101 micromolar per liter, so the same as 1.1 milligrams per deciliter, and normal electrolytes apart from a raised calcium of 2.7 millimolars per liter, 10.8 milligrams per deciliter. His plasma albumin level was normal at 40 grams per liter, 4 grams per deciliter. His X-ray KUB is attached. So the first question is, what anatomical changes are visible in the given X-ray? Dr. Atif, you're muted. Could you just unmute yourself?
Thank you. So guys, if we look in this, the question says what anatomical changes are visible in the given X-ray. Remember, when we are referring to any X-ray, first we need to have a good knowledge of X-ray, plus we need to have a good knowledge of the patient, because we are not treating here X-rays. We are treating here a patient, and patient came with a complaint. And these scenarios are a help to understand what has been given within these given X-rays. So this is the story of a 30-year-old person who presented with right-sided pain. So a pain, and that is agonizing, and that radiates from where? From the loin to groin. So we're talking about on the left side, the pain which is radiating from loin to groin. So now that is my clue. So with this clue, I'll come to this X-ray. And when I look into this X-ray, what is visible to me, first I should look for the normal structures, which are nicely being shown up here. So these normal structures, which are nicely to be shown up here, we can see that within this X-ray, I am looking at the lumbar spines. I'm looking at the pelvic bone, the upper end of the femur. And then now I'm looking for other possibilities. So a very obvious shadow, which has been shown in this image at this place. So this very obvious shadow, to me, it more like to be a calculi, to be a stone. Now, if you refer back, when we were talking about the ureter and the pathway of the ureter, the relation of the ureter with the bony landmark, do you remember we talk about tip of the transverse processes of the lumbar vertebrae are closely associated to the pathway of the ureter. So you can see that this lumbar vertebrae, and look at it, it's transverse processes, and just at the tip of the transverse process is just showing an opacity. And it's nothing but, to me, more likely a calculus which is being present within the ureter. And it's been clear from this vignette where we are looking at a pain which radiates from loin to groin. And then if you look at the labs, the pain got relieved after he gets a strong injection, a painkiller. And then when we look for his chemistry and the other analysis, we found that there is blood. And why we are getting blood? Because this stone is moving. This stone is moving, it has sharp edges, and they are causing trauma to the wall of the ureter. And that is the result of making this urine or urine mixed with blood is being passing out. And then all these changes, the biochemical changes, which will be taken later part by Dr. Ahad and Dr. Jabbar. So this X-ray, what anatomical changes are visible in this X-ray? Rest of the anatomical features are fine, but we see an unusual opacity, and which is being present at the tip of a transverse processes of the corresponding vertebrae. So this should be the answer for this given question. I hope we are right for that. If there is any question, please feel free to write. Now, coming to this, the question number 11. Is there any concern for question number 10? Anything which is not clear? I don't see anything visible on the group chat. So I'm going to question number 11. And the question 11 says, describe the normal anatomical constrictions of the ureter. So we emphasize in the lecture, we emphasize in the labs. On the pathway, the ureter, when it leaves the kidney and its destination to reach the urinary bladder, it shows 3 anatomical narrow sites. And these 3 anatomical narrow sites are what? These are where the renal pelvis becomes ureter. And that we call it as pelvic-ureteric junction or uretero-pelvic junction, PUJ or UPJ. Second part, when it crosses where? This is my pelvic brim, either pelvic brim or the bifurcation of common iliacs. These are the same reference points, the pelvic brim or bifurcation of common iliacs. And the third, when it enters the urinary bladder, vesico word comes from bladder, vesico-ureteric junction, the place where ureter is connected. Ureter is opening in the lumen of the bladder. So that's the vesico-ureteric junction. So 3 points, pelvic-ureteric junction, when the ureter crosses pelvic brim or the common iliacs, and the third one, when ureter is joining the bladder, so vesico-ureteric junction. So these 3 are the normal anatomical constriction sites. Guys, these sites are just normally narrow. It's fine. These stones, when they migrate, usually they stuck in these narrow sites, and they are helpful for picking up these stones on their pathway, these calculi on their pathway. I hope I have answered this question. If there is any concern which is related to this, please feel free, write in the chat so I can be back to you with my answer.
Right, so feel free to keep on writing your questions. So let's move on to number 12, calculate this patient's filtration load for calcium and explain your answer.
I'll have a go at this question.
Yes, please.
Okay, let's go back to the scenario. It says his plasma biochemistry showed a normal plasma creatinine of 1.1 milligrams per deciliter, a normal electrolytes apart from calcium, which is raised 2.7 millimoles, which is 10.8 milligrams per deciliter. The normal calcium in milligrams per deciliter would be around 9. Okay, so so if you're looking at calcium, around 8 to about 10 is considered normal calcium, milligrams per deciliter, sorry, for normal calcium. So this guy is raised maybe to the little bit over the upper limit. His plasma albumin is normal, 40 grams per liter, and the normal is around 35 to about, I think about 50, 55. Okay, so it says calculate this patient's filtration load for calcium. The formula for filtration load would be glomerular filtration rate multiplied by plasma concentration of the particular thing you want to calculate. In this case, calcium. Okay, so his calcium is 10.8 milligrams per deciliter multiplied by glomerular filtration rate. How do we get glomerular filtration rate now? Because we're not given inulin, we're not given creatinine, but we are given the normal plasma creatinine value, which is normal, 1.1. And if you remember back to my lecture on using plasma creatinine as a marker of GFR, you would remember that around 1.1 grams per deciliter equates to about 125 milliliters per minute. So if we assume that the GFR is 125 milliliters per minute, and we assume that the calcium plasma value is 2.7 millimoles per liter, or 10.8 milligrams per deciliter, we multiply 125 by 10.8, and that will give us our filtration load for calcium. But it's not as simple as that. Nothing in life is. And the reason is this. I am assuming that Dr. Hamdan told you that calcium that is transported in plasma is transported either in a free form or a bound form. So if this guy's albumin is normal, you now need to figure out how much of the free form of the calcium this guy has. In other words, I think it's a 60-40 ratio. So the bound form of the calcium, the one that is bound to albumin, will not be filtered. Only the free form of calcium will be filtered. So you now need to figure out, by using this proportion that Dr. Hamdan gave you, how much is the free form. Take that fraction, multiply it by 2.7 or 10.8, and then multiply that by 125 for the glomerular filtration rate. And that will give you the exact filtration load, simply because the bound calcium will not be filtered through the ultrafiltration membrane. Once again, keep in mind the ultrafiltration membrane works on two very important properties. Number one is charge, that's positive or negative, and number two is on molecular size. So large molecules such as albumin will not be filtered for both those reasons. Albumin at physiological pH will be negative. Albumin is a very large molecule, you know, greater than 68 or 70,000 and so on and so forth. Calcium, on the other hand, is a very tiny molecule, okay, compared to albumin, obviously. It will go through the ultrafiltration membrane. The same, by the way, applies to negative ions like chloride and bicarbonate and so on. Even though the basement membrane is negative, these ions are small enough to pass through that membrane. So the ions, the negative ions and the positive ions will go through the membrane. So keep these things in your, in your mind as you are looking at this ultrafiltration. So to summarize very quickly, the calcium comes or is divided into two forms, the bound calcium and the free calcium. And you need to figure out how much is the free calcium. Take that proportion, multiply it by 10.8, okay? And then take that value, multiply it by 125, that will give you the filtration load for the calcium. Thank you.
Wonderful, Dr. Al-Jawad. Thank you. Just before you go on to questions for Dr. Atif, there were a couple for you. Taking 40% of 10.8 gives me free calcium concentration. That's a question that was asked.
Yes.
Wonderful.
Okay.
Also,
so 0.4, sorry, 0.4 multiplied by 10.8, whatever that answer gives you, you then multiply that by 125 and you got your filtration load for calcium.
So the next question is, would you assume size is more important than charge in transport?
They are equally important, because if you go back and you look at the presentation and they looked at these dextran molecules, where you had big dextran molecules that are positive charged, small dextran molecules that are positive charged, and they did exactly the same thing for negative charge. You would find that the smaller molecules, irrespective of charge, are able to get through, and the larger molecules, or the bigger size molecules, tend not to get through the membrane. And who has a worse effect on moving through the membrane are the negative charged ones. So in a general sense, yes, size, molecular size is a lot more important than the charge.
And this other question was, should we not be conversing milligrams per deciliter to milligrams per milliliter?
Yes, you should be. You should be converting milligrams per deciliter. All you do is you divide by 100 and you got it milligrams per liter or milliliter, whichever one you want to do. Because all GFR is given is in milligrams per minute or milliliters and so on and so forth.
Okay, that's wonderful. Going back to Dr. Atif, sir, could you answer a couple of questions that were asked to you? Could you unmute yourself as well, please?
I think so. Thank you, Dr. Junaid. I will take these answers because I'm working on something which will be an aid that I'll be using at the end of this, and I'll be showing you why it's in ureter and what are these. I'm looking at those questions and then I'll be answering you on the same X-ray. I have done some hand drawings and I'm sure I'll be presenting it to you shortly when we'll finish this whole discussion. So now the question which is here for me, and that is question number 13. And that says, what is the likely cause of the pain in this patient? Guys, you know that? Can you see my cursor? Okay, so now people are saying no.
Dr. Atif, because a different person is sharing their screen, they cannot see yours. So you have to initiate a screen share from your side.
Okay, fine. I will discuss that on. So I will not annotate at the moment. So guys, now regarding this question, what is the likely cause of the pain in this patient? As I said, this stone, this calculus is in the ureter. It's stuck in the ureter. Otherwise, if it's not stuck, it could have fallen down. So it's stuck in the ureter and it causing, it causing the obstruction to the flow of the urine. So as a result of that, then when the stone has stuck in the lumen, so as a result of that, the urine is not passing. So this urine which is accumulating within the length of the ureter, it causes distension of the wall of the ureter. And we all know the wall of the ureter, one of the contributing factor here is the smooth muscle. So once we have distension on that, so this obstruction which result to the distension, stretch and all that, and this is how the pain receptors, the pain has been carried over and it has been gone to the specific segment of my spinal cord. So the distension due to obstruction and the stretch of the smooth muscle will result in this pain. I hope I'm clear with this answer. If it's not clear, please write it on the chat box so I can come up with more.
Okay, wonderful. We're waiting for questions, so we go on to the final question. So describe the metabolic predisposition to his current problem and suggest an etiology for it.
Okay, I'll start with this one. Maybe Dr. Abdullah can chime in a little bit later. Hello?
I think Dr. Abdullah is muted.
Okay, never mind. I'll start off. So it's evident from the case presentation, both in terms of the renal calculi and the elevated calcium, that this patient has a raised plasma calcium concentration, and this could possibly lead to the hypercalciuria, high levels of calcium in his urine, and the formation of, as Dr. Atif mentioned earlier on, a stone. So in a patient, that's 30 years old, this is a pretty young guy. The thing to look for in this case is to look for what is his levels of parathyroid hormone. Now, if you think back to parathyroid hormone, released obviously by the parathyroid gland, posterior to the thyroid gland, and PTH will cause an increase in plasma calcium. So your next order of business with this patient is to figure out what his level of parathyroid hormone is and whether or not he's suffering from a primary parathyroidism. And if he is, then that may explain this high level of calcium, okay, and the formation of the stones in his urine. So this is what you need to exclude in terms of his metabolic pathway or his metabolic predisposition to him getting stones and so on and so forth. So the need here is to do a PTH level, because obviously high levels of PTH will not just increase plasma calcium, it will also bring about an increase in reabsorption of calcium in the early distal convoluted tubule. So that's what you need to do.
Dr. Abdulahad, is there anything you'd like to add?
No, it's okay. Dr. Jabbar has explained it very nicely.
Okay, everyone. Again, if you have any questions, just write them down in the chat function. So Dr. Atif, going back to you, would you like to share your screen?
Yeah, I like to share my screen. My presentation is ready. So I'm about to share my screen. So my screen is visible?
Yes.
Okay, perfect. So now guys, coming to your concern. Okay, there I am. Let me make it a laser one. Okay, so now I hope you can see it now. So here in the same X-ray, I have drawn this outline of the kidney, and there you can see the ureter. And if we look at that, you can see this ureter is passing and the calculus is visible. It's far down from the pathway. This is my sacrum, and these are my lower lumbar vertebrae. Look at the transverse processes and look at the stone. It is coming in the pathway, and this is how the ureter is going down to the urinary bladder. So that explains. And if I want to add further, I can show you in this image. Look at it. I was trying to show you this. So this was going near to the tip of the transverse processes. So that explains that it is in line with the ureter. If you look further, now look at this. And then going further, this is in the proximal ureter. And this is what you're seeing in that particular case. So this is the calculus, which is in the mid ureter. Am I clear? So if I'm going back to my slide, so now the same X-ray is for you, and there you're looking at what is there and why I'm saying it's the line of the ureter. I hope I'm clear with this explanation. If there is any concern, please write me in the chat. Any
Wonderful. Thank you, Dr. Atif. Sorry, you were saying something, sir?
No, I just want to know, is it clear to them or still they need?
I think while people are typing, I believe there is a question from scenario 2. And I believe this was either for Dr. Abdulahad or Dr. Abdul Jabbar. So the question was, can we say that the lower sodium can also cause lower glucose because less is available for as a co-transporter, and lower blood pressure because of less sodium attracting water?
No, as Dr. Abdul Jabbar has nicely mentioned, that it is the Addison's disease in which there is decreased cortisol level. The less glucose is because of decreased cortisol level.
If I can come in here for a second.
Please go ahead.
Hisham, you are mixing two different things here. And let me try and explain. So as Dr. Abdullah had pointed out, you require aldosterone to reabsorb sodium in the distal nephron. Distal nephron meaning cortical collecting duct, medullary collecting duct, by the principal cells. He also mentioned to you that by the time the sodium gets to that level, you've pretty much absorbed 90% of your sodium. Okay, so that means whatever sodium you have is just a tiny amount that you're just regulating, so that all you do is you excrete just about 1% in the urine. Now, let's come back to your question. Now, the sodium, even though it is decreased in the plasma, I think it's about 120 something odd, that 120 something odd is being filtered from the glomeruli into the Bowman's capsule. At the same time, the glucose is being filtered. The low amount of glucose is being filtered into the Bowman space. Now, that sodium, remember that 70% of that, 70 to 80%, as Dr. Abdullah had pointed out, 70 to 80% of that is reabsorbed in the proximal convoluted tubule. That 70 to 80% of that sodium that's reabsorbed is sufficient to bring in all of your glucose as well. So even if the glucose was normal, in other words, 60, 80 milligrams per deciliter, that low level of sodium is sufficient through the SGLTs to bring in all of the glucose back into the blood. So that decrease in blood glucose concentration is not caused by the decrease of the sodium in the plasma. Hisham, did you get this?
Okay.
Okay, Dr. Junaid, Dr. Junaid, there is one student, Aris. He asked me a question, and his question says that in the X-ray, there were some calcification which were shown in the bladder region. So now these calcifications, they are out of the line of the bladder, and they are not connected to this thing. They are phlebolytes, and we need not to pay attention for these, which are just so down, and they are not within the lumen. But to confirm this kind of entity, we need to have a contrast study to confirm that these opacities are either they are present within the lumen or they are lying out of the lumen. And after that, we can say that, but it's very clear within this X-ray that they are lying out of the urinary bladder. I hope I have answered your question. Aris, did you get it? Thank you. So I'm done, Dr. Junaid.
Wonderful. Thank you, Dr. Atif. I think this is a bit of a self-explanatory question, but I'll pass it on anyway. Should we know the normal values of electrolytes and protein concentrations in blood, or will it be given in the exam?
Generally, because this is a first-year class, we will give it in an exam if we have any questions on them. As for that question of do you need to convert things from milligrams to milliliters, again, because this is first year, we will ensure that all values are given in the units in which you were taught. So if it's milligram per milliliter, we'll give it to you in milligram per milliliter. However, we will not say that 0.6% or 60% will be bound and unbound. These are things you need to start learning.
For the second scenario, what about the secretion of glucagon to elevate glucose levels in the serum?
Dr. Abdul Jabbar just explained this.
The glucagon level in that particular patient is probably high because your glucose level is extremely low. Okay, but keep in mind that glucagon and insulin work synergistically. In other words, they need to work together. So you actually need insulin to make glucagon work properly. Now, if your glucose level is so low, your insulin level is also terribly, terribly low. So, in other words, you know, it's a double whammy. The guy is not going to be able to secrete the amount of glucose he requires.
Okay, wonderful. Hopefully this answered the question. So, does anyone else have any questions in their mind? Anything which isn't clear about these particular scenarios that you would like to ask the doctors now? Also remember that you don't have to, you're not limited to ask them now. You can always email them with questions later on. I'm sure all of them would happily comply. Right, so I think if there aren't any other questions, I think that's it, unless any of my colleagues had anything to add about the particular scenarios. Thank you everyone for attending the session. I hope it's been productive for you, and I hope it's been a good review session for you as well. Again, any questions, any concerns, please feel free to email any of us. Thank you very much.
Dr. Junaid?
Yes, Dr. Jabbar.
Dr. Junaid, just one little thing here, while we still have, I don't know how many students still online, how would the students like that we do the physiology review?
So I think there is a review session that is scheduled for next week as well. There are a few review sessions that are there. So I think, Dr. Abdul, what you're asking is you'd like to know how they would like to do this, or what they would like, what the concept
exactly what it is they would want us to do. Start off with a question, do an explanation, or they send us the question, or because I'm happy with anything. If they send me a list of questions and then we meet next week, you know, we can discuss those questions.
I think that would be better. If they send us questions, then we'll discuss. Otherwise, I mean, we have to open the topics and start all presentations. That would be better. If they send...
No. We don't want to rehash the entire lectures all over again.
Exactly. So if there is specific questions from a specific part of the lecture, we can handle that question.
Okay.
So we'll
I think this is entirely down to you. I think if students, of course, if they have any specific questions, they can email you and you can address them for the benefit of everyone who attends that session. But then if there's any other things that you think the students would benefit from, then that's entirely up to you. I think this, of course, I suppose would depend on student demand on what they want.
Okay. So I'm looking at the comments on the right-hand side. Most people seem to think we need something to start with. So if they can send me questions, I will compile them, or Dr. Abdulahad for that matter. Between us, we'll compile them. At the same time, I will seek out a few questions on the lectures and try and put down, as I did in my lectures, you know, a little explanation box. And then we can start with those as, you know, as stimulus material, if you want. Is that okay for the 60-odd people that are still online? Just say yes, yes, yes.
Okay, guys.
Lots of yeses.
So for anatomy, we will follow the similar thing as you guys need. Just email me and I'll follow what you need.
Okay, wonderful. So I think if that's it, could someone's asking for anatomy review session with example questions.
I said okay.
Okay. Okay. So could someone, the main host, could you transfer being the main host to any one of either myself or Dr. Abdulahad or Dr. Abdul Jabbar, Dr. Atif? We'd like to kind of continue this discussion very briefly after the students have gone.
Dr. Junaid, I think we can end this meeting, and you made a new meeting right now, and then we can start.
All right. Okay. Okay. So I'll just send all of you a link, and then we can start a new meeting after.
Makes sense. That'll be better.
Wonderful.
Good.
Thank you.
Okay, thank you so much, everyone.
Thank you, everyone.